Center for Drugs, we have the ARIA, Active Risk Identification Analysis System, which is part of our review process. And our colleagues in the Centers for Biologics Evaluation Research, or CBER, have PRISM, their branded name for their vaccine program, and BloodScan for their blood transfusion, blood product program. While the use of claims data and other electronic health data isn't new with Sentinel, it's been used for probably about 30 years in some way or another. But what Sentinel provides us that's different is the large size of the database, around 200 million lives, and the speed with which we can get the results that we're seeking, largely facilitated by the Common Data Model and the programs that you'll learn more about. It complements other types of data we have, such as adverse event reporting data and other types of epidemiological data. It's not a replacement for those data. But as I said, the timeliness changes the time scale from months and years to weeks in many cases. So this has been quite helpful to us. For those of you who've attended our public meeting, there's an annual public meeting. We had the ninth, was it the ninth one this past year? Yeah. We presented many examples of how we've used it, drugs for diabetes, anticoagulants, etc. The system isn't static, it's continuing to grow. Maybe you'll hear about some of that today. Tree scan methods for signal detection, mother-infant linkages for pregnancy, for medicines used in pregnancy, and looking to expand from a primarily outpatient population to one that's more enriched with inpatient data through the incorporation of HCA. Like a lot of other of our drug regulatory programs, transparency is an important part of that. We have a lot of data available on the Sentinel website. It's not an FDA website, it's a Sentinel website, though I believe there's a link from the FDA website. And we're opening up training like this to really make this even more transparent to all of you. And for those of you who follow the regulatory and legislative space, part of our commitments under the goals letter for PDUFA 6, Prescription Drug User Fee Act, iteration 6, are to make Sentinel more transparent. So with that, I think I will turn over to Rich Platt, who will tell you more. You have a full day today. It'll be a fairly technical day. You'll hear from Jeff Brown about the program in detail and the whole concept of a distributed database. Kevin Haynes will talk more about what kinds of questions these databases can answer. And then Judy Marrow will spend the afternoon talking about the specific tools in Sentinel used to answer these questions, and Rich will wrap up at the end. So we have a number of people in the room. I believe we have quite a number of people participating remotely. And so I wish you all a good day. Rich?
Thanks, Gerald. So I'm speaking on behalf of the many Sentinel investigators, of whom there are a fair number in the room. Could I just ask the folks from the Sentinel Operations Center and the data partners to stand up for a second so you can see who they are, because it's possible that not every question you have will be answered during the formal presentation. You can ask anybody at any time about that work. The Sentinel operates as a contract from FDA, and although my shop, Harvard Pilgrim Healthcare Institute, is the contract lead, there are dozens of organizations and literally hundreds of professionals who make Sentinel work. Our goal for today is, as Gerald said, first to provide information about how Sentinel works and what makes it different from other kinds of programs. I'll say, in addition to the speed that Gerald mentioned, which really, in my view, has been transformative. Another really important feature of Sentinel is its commitment to robust and reproducible results. That is, FDA has been extremely clear that in order to be able to use the kind of information that Sentinel provides to support regulatory decision making, there has to be an extraordinary degree of reliability about the agency's capability to go back to not only to the original electronic data, but also when necessary to go back to providers and get original source information such as hospital discharge data to confirm specific outcomes or exposures that are critically important. So that's the, if you ask what have the several years been devoted to, they've been devoted to creating an architecture that allows many organizations to provide information to FDA in a timely way, and to creating the capability to be able to assure that when needed, it's possible to go down to very granular information and ascertain its accuracy. FDA was always clear in creating Sentinel that it expected that the resources and capabilities that Sentinel creates would become a national resource for other users and other uses. And another goal of the training that we're starting today is to help make it clearer what Sentinel is capable, what the Sentinel capabilities are, so that others could think about using it. High up on that list is the IMEDS program that is part of the Reagan-Udall Foundation. It's the FDA public-private partnership. I know June Wasser, who's the executive director of IMEDS, is in the room. The anticipation. June, why don't you go like that? IMEDS is specifically created with the idea of providing the ability for pharma first, possibly others, to be able to work with the Sentinel data partners outside of the FDA contract. But our view is that the resources that Sentinel has created, both the data sets that the data partners themselves own and control, and the tools that are being continually refined, may be of more general use, sometimes for single organizations to use within their four walls, sometimes as part of a multi-site activity when that makes sense. So our goal is to begin that conversation. We are optimistic that there will be today's presentation is intentionally geared to describing what Sentinel is, how it's organized, how the kinds of questions that it can address now, where it might be going, and to provide some examples. We are optimistic that within the next few months, probably in association with the next public workshop in February, there will be another training that builds on this one. So it won't repeat today's content, but it will do a substantially deeper dive on what the Sentinel reusable tools do and how they do it and how they fit into the general schema of using electronic health data. If all goes well, we hope to follow that sometime in the future, not scheduled, with yet more detailed training that would allow users to work with knowledgeable personnel to get hands-on experience actually using the tools. Those tools are all on the Sentinel website, as Charles mentioned. All of the intellectual property that Sentinel creates is put into the public space and put on our website. So there's no requirement to have sort of additional training with or by us, but we do intend to make that available if we can. So with regard to how we're going to spend the day, here's what we're hoping to accomplish today. Talk about what Sentinel is, how patient care, face-to-face care between individuals and their providers turns into data in the Sentinel system, the kinds of data that are available and what populations there are, what kinds of things Sentinel can capture, and we'll also talk about the kinds of things that it can't capture. And as I think you've seen on your on the schedule that the agendas that we've put out, this is how we propose to lay out the day. Purposely trying to build in enough time so that there can be real back and forth with the presenters, and we hope that by the end of the day that there will be a pretty good shared understanding of where Sentinel is now and the kinds of things it can do. So with that, I'm going to ask Jeff Brown to come up to the front and take over. So Jeff is based at the Sentinel Operations Center, and Jeff was really the principal architect of the Sentinel system and continues to provide an important leadership role. Okay, Jeff, thanks.
Thank you, Rich. It's really great to be here. Let me get myself situated. So thanks for that introduction. So I'm going to spend the next set of time up till almost 11 o'clock, really at a pretty high level, discussing the Sentinel data, the kinds of data that exist that enable us to do the work we're doing with FDA. Then Kevin Haynes is going to do a slightly deeper dive into the particular kinds of data, the data elements, exposures, outcomes, covariates. I'm going to spend my time thinking really about the US healthcare system and the data that are generated every day and how we're trying to make use of those data for FDA surveillance activities. So the Sentinel Initiative is the broad program that we work within. We're going to be spending our time today talking about the Sentinel infrastructure. So the infrastructure we're talking about, really think of the data sources and all of really the researchers and partnerships that we have that make up the Sentinel system and the FDA Catalyst. So I'll make a quick distinction between the two. The Sentinel system on the left, think medical product safety surveillance. Catalyst on the right can handle interventional studies that might be touching patients or collecting information. Overall, the infrastructure can support both of those activities. They're slightly different activities. We're focusing on the infrastructure in total during the day. So for a little framing, the Sentinel infrastructure requires a fair amount of oversight. It's even more than just a fair amount of oversight. Really a big chunk of work goes into thinking through how to make a system this big work. So there is what we call a coordinating center. For our purposes, the coordinating center is really everyone in the Sentinel partnership. And I'll show a slide in a moment showing all of the institutions that are part of the Sentinel partnership. Here in the middle, the circles are really the operations center. So I sit at Harvard Pilgrim Healthcare Institute. We house the operations center for Sentinel, and the partnership is much broader than that. So we have a methods core, an applied surveillance core, think methodologists and pharmacoepidemiologists that we partner with that support our work. We have a data core. So Kevin Haynes, who's going to speak right after me, is part of the data core. He's part of the expertise that helps us manage and use these data appropriately. And all of our partnerships, all of our partners are included in the planning board, and then we have privacy panels, and then other groups that we either appear, will create for help to help us with particular problems or topics. But it's a broad group of folks who are able to do this together. The operations center, where the those three circles in the middle, that's the group that sits at Harvard Pilgrim. Think of us as responsible for the day-to-day operations of the network with support from everyone else. So we handle the distributed network, which I'll talk about in a moment, the secure way that we handle doing our work, expanding capabilities. So over the last, so I've been doing this since 2008, so long that is, over the last 9 years or so, Sentinel data partnerships have expanded, our analytic capabilities have expanded, and the Operations Center is responsible for making that work. We have a common data model that I'll describe. It's our responsibility there. And then all of the querying, the analytic querying that you'll see in the afternoon. I should have paused for a moment. The afternoon will be describing all of the work that think more of the analytics. We're starting with data, and then in the afternoon you'll hear Jude Marrow describing the analytics capabilities of Sentinel. Data refreshes. I'll just note this is not a static database, as Gerald actually noted. The data are being refreshed quarterly, and really there's always new data coming in. So where there's new data coming from? Well, people go and visit their doctors, and they go to the hospital, and those data flow through the healthcare system, and those eventually end up into the data resources that we have. And this Operations Center also handles the technical infrastructure to some of the security, some more of the security features that we use to communicate. The Sentinel system, or our partnership, includes there's over 30 different institutions. If you count here, you won't count 30, because some of these are actually networks of networks. But Harvard Pilgrim subcontracts with, actually it's slightly more than 30 different institutions to try to make this work. And we think it actually works pretty well. But it's a big group, and what are the folks doing here? So think scientific expertise, clinicians, epidemiologists, data scientists at all of these institutions help us do the work we do. And we also have a set of partners that also contribute data to the system. So you can see the middle layer are our data partners. To be clear, it's not just data. They have data scientists and epidemiologists and clinicians there as well that all together form this partnership and this collaboration. This is the set of partners. There are 17 data partners within Sentinel. Again, you don't count 17 here because Kaiser Permanente and the Healthcare Systems Research Network is actually a group. So there's several Kaiser regions in here and several Healthcare Systems Research Network groups there. So that's just why the numbers don't add up if you're counting. Our philosophy on the data is that all of the partners keep their data and they have full control of it. At Harvard Pilgrim, where we sit in the Operations Center, there is no big database. I've actually never seen anyone's data resources. They sit behind those firewalls, and our partners maintain full control of them. We have really pushed the envelope on minimum necessary. So what we do is only get the information needed to answer the question that we're asking. And it's really important to keep that in mind. We've developed analytic approaches to minimize the amount of information that has to be shared in order to answer the question. Our partners don't share information with each other, so that's why there's this central coordination role that we have at Harvard Pilgrim. So we can see the information, but the partners can see each other's is our rule, and if there's any need to do that, there would be a conversation to do that. And there are reasons you might do that if there's a lead for a particular project that sits as a scientist at one partner might need to see information from another, and then we'd be able to do that. So I'm going to now shift gears to talk about the U.S. healthcare system. There really is a U.S. healthcare system that we can learn from and describe how that information eventually flows through into data that we can use for medical product safety surveillance. So patients are interacting every day in the U.S. healthcare system. Those interactions generate information. It generates data. So the data might be an insurance claim. You visit a clinician, you go to an annual checkup, your clinician will send your insurance company, if you're insured, a bill. It's a claim for reimbursement. That claim has information on it, and it's well captured and well standardized. That's the idea of claim system. That visit will also generate clinical data. The clinical data might sit in the electronic health record of your clinician. And it can generate additional information as well as patients flow through the healthcare system. What we're trying to do is make use of that routinely collected data for this other purpose. So we have a story of Bob as how we try to describe this try to describe the healthcare interaction. So Bob lives in Boston, and he's a Harvard Pilgrim member. He's a member ID, he's a date of birth, we know he's male, we know where he lives. So Bob has a visit, and I'll just note the timeline. It's 2011 to 2014. Bob didn't have a good January 1st. He began the new year with an influenza visit with pneumonia. And that was an encounter that he had at a medical facility, and that gets recorded. There was also a dispensing of, I have to use my glasses to see these now, a dispensing of an antibiotic at that point. There's another visit about a year later with an appendectomy and an emergency department visit and a hospitalization for a few days. Again, you can imagine how that would flow through the system, information being captured during this time. Now there's another office visit 6 or 9 months later for hypertension. That visit also generated a dispensing of an antihypertensive, and then a routine office visit later that year. So the way we think of the world is Bob is a Harvard Pilgrim member. Bob was a member for 1,000 days, little more than 1,000 days, that we at Harvard Pilgrim can observe all of the clinical care provided to Bob that is reimbursed. Or actually, I shouldn't even say it that way. That has been submitted, because it doesn't need to be reimbursed for us to be able to see it, as long as a claim is submitted. So Bob, during this time, is a 47 to 50-year-old male. We observe his time for a little more than 1,000 days. We expect to see all the care that happened to Bob during that time. That's the key for us to be able to do the safety assessments that we're doing. We expect to see all the care during this window of time. If Bob chose to leave Boston for whatever reason and go out to California and become a Kaiser Permanente member, Kaiser Permanente is another one of our Sentinel data partners. Kaiser, it will look like a new person to Kaiser. For Harvard Pilgrim, our member disappeared. They're no longer a member, they're no longer enrolled. But now Kaiser has a new member, and the story will look the same, right? There's encounters, there's diagnoses, there's dispensings of medications. There's even here test results. So there was a glucose and A1C test ordered, and you'll see a result. Another encounter, this is an emergency department visit for a stroke and led to a hospitalization, and then another dispensing. For Kaiser Permanente, Bob is a 50 to 52-year-old, and they have about 2 years of observed time, 640 days of observed time. The distinction, the reason we tell the story is when Bob left Harvard Pilgrim, he is gone. We don't see what happens to him when he lands in California and that care. So these are really two distinct people from the construct of, this is a US healthcare system issue, right? These are two distinct people from our construct. And they'll actually be counted twice when we count up all the people in the network, which is why you sometimes hear, I've heard before, companies or organizations say, we have 1 billion people in our database in the US. Well, that's the way you get 1 billion people is you have a lot of time and people move in and out of health insurance. So this will look like two different people in our system. What's unique here, and we'll point some of this out further along, is because Kaiser's an integrated delivery system, so they own hospitals, they own clinics, they might have a little bit more detail than a claims database would have without doing linkages. So we now know that Bob was a white male. Before we just knew he was a male. And we might get those test results because at Kaiser, you might get test results from the integrated delivery system because they went to a Kaiser hospital. Our other partners can get those results. It requires linkage to other systems versus it being integrated into the system. So there's a subtlety there as well. This is really just a recap of the kinds of data that are collected and why. The administrative data are collected, think for payment. It's really for payment and management of the insurance system. There's the clinical data that's collected to manage care. What I didn't mention yet is registry data. So registries are things like a birth registry, a death registry. So states have birth registries, death registries, immunization registries. Those are also collected during the normal course of care. And we can make use of it, and you'll note there's some of our partners have death data and cause of death data. Well, where are they getting that? One of the places they're getting that is the state death registries. So I'm just going to go through and put all of these up. We're trying to highlight the variability in our partners. We have 17 data partners. They're not all the same. They don't all look the same. So our challenge is to figure out how to best use those data together to support FDA's safety surveillance needs, and also how to make sure we don't use the data in a way that's inappropriate. So you have to think of it from both sides, and that's why we have so many partners and all of our data scientists that help us make those decisions. 7 of our partners really are claims-based. They're large insurers, and the majority of their data are claims. Some of them have linked to clinical data that you'll see, but the majority of the data are claims-based. The integrated delivery systems are just about 10% of the people and about 16% of the encounters. That's because they actually go back farther. They go back, some of our integrated delivery systems go all the way back to 2000. So we'll have more encounters for them. And we also have, and I'll talk about this specifically at the end, a standalone EHR is what we're calling it here. It's a hospital system. It's a large multi-state hospital system that has really think inpatient data. So they're separate, and we note it separately because it's a very different kind of data that you can do some things with our inpatient data that you can't do with the insurance data and vice versa. So we kind of leave it separately to make that distinction. So what's in the database? The Bob story was trying to highlight the idea of well-defined person time. So when you're insured, you're between your insurance start date and your insurance end date, that's well-defined person time. Between those dates, we should see care provided to you by clinicians. We should see medication suspense. We should see hospitalizations. All of those should be seen because all of those should be billed. So that's how we take use of that well-defined person time. So you'll see is over 200 million members, 180 million or so have medical and pharmacy benefits. That's just another complexity in the US healthcare system. Some people just have medical benefits. If you don't have medical and pharmacy, you can use those patients for some things, or there's enrollees for some kinds of questions, but not other kinds of questions. So you have to be careful how you're using it. An important number here is 43 million current accruing data. These are current patients accruing data. So if you look today, there's about 43 million patients, really enrollees, at our data partners that are accruing information as we go along. And you can see billions of dispensing, billions of medical records. It's a very large data resource. This is just another way of thinking through some of the variability. The data don't start and stop all at the same date. And this will likely be different tomorrow as a new data partner adds another 3 months or even 6 months of data. So we always have to be paying attention to what questions being asked, the time period, and the data we have available. So you can see all of this variability within just start and stop dates. And there's lots of different reasons for the start and stop dates, but this is the environment that we're living in. Enrollment time. Remember, this is really an insurance concept. If you're insured, you have a start and a stop date. Really, it plays out to be about a third, a third, a third. About a third of our members have a year or less of information. in the database. And remember, that's growing over time, so their information will expand to more than a year as we keep growing the database. About a third have 1 to 3 years, and a third have over 3 years of information at this point in time. So this was in May of 2017. Remember, when you take those slices of time, that's what happens. And people who might have had 3 years of data, like Bob at Harvard Pilgrim, as soon as Bob moves to Kaiser Permanente in California, Bob all of a sudden has 1 month of data, right? So that's how it plays out. So that's why these numbers kind of look this way. There'll always be a bunch at the low end of the scale as members change insurance companies. Just to take a look at dispensings. So there's obviously more than 400 million, and the 400 million isn't that the U.S. healthcare system somehow dropped hundreds of millions of dispensings a year. It's the data. Not everyone has refreshed their data when we did the data cut, but you can see 500, almost 600 million dispensings a year that are accruing that we can use for to support FDA's needs. The big jumps, again, this isn't. The big jumps are when new data partners appear. So it's not that between 2007 and 2008 we used twice as many dispensings, or had twice as many dispensings. It's that more data partners were added, and that's the year their data started. So that's how this plays out. The partner populations are also pretty variable. And it's just, again, the nature of the healthcare system. If you're an insurer that is in the South, you might look a little different than if you're in New England or you're in the Pacific Coast. And even the kinds of members you insure. So if you do have a large individual insurance market, it might look a little differently than if you have lots of large companies that you're insuring their members for, right? So that's why you'll see all this variation. So this is what the system looks like in general. Although it's not here, typically the way I describe the population in Sentinel is it's a little bit younger than average, and that's because we don't have yet the Medicare data. So if the Medicare data aren't in, that's where the older folks will be, so that's why it skews younger, because we just don't have it. We do have patients over 65, but the Medicare population is really the big bolus of those information. But you can see we do have one partner that has, this is just the orange is showing one of the data partners, actually has a pretty big population at the older age groups than the average across, and one's actually skews the other way. This is okay. The reason that the way we handle this kind of variation, and I have some notes here about it, is you either do it through study design, self-controlled designs, match designs, because the idea is a 50-year-old patient in one database, a 50-year-old male with hypertension in one database and no other condition should be about the same as a 50-year-old male in another database that also just has hypertension as a diagnosis. So that's how you can use all of the data together. Even if one database skews old or one young, you're not studying databases, you're studying specific cohorts of people, very specific inclusion-exclusion criteria to try to make them look as close to each other as you can. So that's how you do it. You're not studying databases, but you're studying particular groups of people, and that's how you're able to use the data in this way. So now I'm going to shift to, and I'll go pretty, well, we'll go pretty quickly through these. It's really making the same point, but data source or data domain by data domain. And I don't want it to sound, let me pause here for a second. We're pointing this out because our data sources are variable. Some have some type of data, I'll describe this, some have other kinds of data. So what that means is when a question is posed, we think through the best way to answer it. It's not always obvious how to do it. The analytic tools that Judy will describe help us either think through how to best ask and answer a question, and then how to best control for any of this kind of variability that we'll see. So I'll take one moment to describe the distributed data network, and how we actually answer these questions. This is, I described 17 data partners. They all have data in some form back at their home systems. We ask them to standardize their data into a common data model, which is what I'll show in a moment. Once they do that, we have a very sophisticated approach to do data checking. We sometimes call it data quality, data characterization. It's data curation, so that the data that sit behind those firewalls at our partners have been very highly curated. So we're very confident that they meet our standards for conformity to the data model and that they make sense. Our partners are critical in helping us do that. So we have a full process. This talk won't go through the data checking and curation process, but that sits behind, or really underlies a lot of what we do here, and why we can, as Gerald noted, answer questions very quickly, because we spend an awful lot of time and effort on the data where they sit, so that when a question comes in, we're not wondering if the data will be there, if the data are of reasonable quality, if it matches the data model as we expect. All of those things have been handled so that when the question comes in, we can focus on answering it and not wondering what the data look like. So the way it works on a daily basis is the operations center is that top box. Really what happens is the operations center sends a query, and Judy will describe the kinds of queries we can send this afternoon. We send it to our partners. Our partners bring it inside their firewalls. They can review the query. The query will come with information about what it is and why we're asking. They bring it inside their system. They execute it locally. The results are then available for them to see and review. And then they release those results back to the operations center for aggregation and reporting back to FDA. So this is, on the technical side, it's asynchronous by design. Those steps are there on purpose, that our partners get a chance to see what we're asking, they get a chance to review results, and then they release those results. There's a lot of reasons for that, ranging from security to providing additional value add when our partners look at a particular topic and can see a result and might actually have something interesting or important to tell us about that data or that question in their system. So it kind of ranges of why it's this way, but it's an important construct of the system. So I mentioned a common data model. So we have really 4 different pieces of the model. The administrative data are laid out here: enrollment, demographics. I described this with Bob. Dispensings. So those are when you go to your outpatient pharmacy and they hand you a bottle of pills. That's a date that someone was provided a certain number of pills. Those pills have a code that's very specific to what was there, and that's all recorded very nicely, actually, the pharmacy data in your insurer's database. So that's where we get our dispensing data. That's outpatient dispensing. And then there's the encounters. Every medical encounter is associated with a set of diagnoses and procedures. And we organize the data in this way, really for analytic flexibility. This isn't the way the data look when they come into our partners. This is how we ask it to be organized so that we can analyze the data more efficiently. Some of our partners have clinical data, think labs and vitals. It's not all labs. We focused on a small set of labs that our partners have extracted and standardized. There's some registry data. For the registries, think death and cause of death. So those are 2 different data streams, actually. So you can get death from different places and you can get cause of death from other places. State vaccine registries, so we have linked to state vaccine registries. We don't do it routinely, but we've done it for certain studies and those data are there. And then we have inpatient pharmacy and inpatient transfusions. That's really that one Hospital Corporation of America that I'll talk about at the end. It's really their data resource right now is what has those 2. So the data availability varies by partner. You can see everyone has demographic information. Everyone except the hospital system has enrollment information, because enrollment's not a construct for a hospital. You go to the hospital, you're seen, you're there for 5 days, and you leave, you're not insured. So hospitals see people from all insurers or not insured. So it's a different construct. Outpatient dispensings, again, everyone but that hospital system won't have outpatient dispensings. Utilization, visits, diagnoses, procedures, everyone will have those. Laboratory results, slightly different group. So I didn't lay out the construct here, but on the left are our integrated delivery systems, in the middle are the claims-based systems, and then we've got the hospital system on the right. So you can see that some of our claims-based systems have clinical data, have laboratory results. Not all of them and not for all labs. This is why we always have to think through every question. Vital signs, you can see it varies again. Registry, a little bit more variation here. This is death and cause of death. So death, think death date. There's a date, and it's important to know whether someone if someone died, the date they died, but you might not know why. And then the cause of death should give the causes. And those are actually different data streams. And then the vaccine data, as I mentioned, and the inpatient pharmacy and inpatient transfusion are only at our inpatient system. So a second about expansion. So I've described our current system. It didn't look like this 8 years ago. It didn't even look like this 5 years ago. We've added new data partners. We've added new types of data within data partners. We've added new analytic tools, which we'll describe in the afternoon. So this has really been a system that's been growing over time, not just because we're adding new data, but we're adding different kinds of data and even different data partners. We're currently working with CMS for them to get access to the Medicare data, and it would be in the same way where we send questions to the data and get answers back, so we won't have a big database of the Medicare data. We're hoping that comes online in August or September of this year. You can imagine it's a pretty big undertaking, and we're actually describing ways of getting the 100% of Medicare data. If you've done research in this field, you hear people talk about the 5% sample and the 10% sample. We're talking about all of the data, which raises the stakes just in how to figure out how to do it, and even just how to process that much data is not particularly obvious when you're running the kinds of queries that we're running. So we're running into challenges and trying to figure out how to deal with them when we're dealing with such size and volume of data, and in a highly regulated environment where you can imagine the Medicare data, access to Medicare data is very highly controlled. So I'm gonna end, I was mentioning this hospital system, and I just wanted to make sure that differentiation was clear of the kinds of systems that we use routinely, and now the Hospital Corporation of America, which is an example of a new partner that we brought into Sentinel. We did so because it met a need for FDA. So this really started when FDA asked for assessments of blood products, and the claims data don't have a particularly good way of identifying blood products at the granularity that was needed, but the hospital system does. So you're not typically going to get a claim to an insurance company that has a level of granularity of a blood product used in an inpatient setting, but the hospital certainly knows what was transfused during that stay. So we went to a hospital system to work, and it was Hospital Corporation of America is now a Sentinel partner. It's actually close to 170 hospitals, mostly in the South. You can see where they're situated, that we're working with. Very large system, so about 5% of all the inpatient care in the US is a pretty big chunk of information. I think we said 50 million encounters currently in the system. Again, it's standalone, so the construct is different. What HCA has very good information about is everything that happens from the moment you walk in the door to the moment you leave. So that's the construct of enrollment for the Hospital Corporation of America assessment. So we can see transfusions that were given in the hospital. I'm mentioning the things that we're focusing on. And inpatient medications dispensed. Again, inpatient medications won't typically be available in a claim at your insurance company. It's just not going to flow through as a claim. But the hospital system certainly knows about it. So that's where we can try to get the inpatient medications. You have to go to the inpatient facility to do it because it's just not submitted as a claim for payment. So it won't typically be there. The subtlety there, and actually Kevin's going to go through all of the levels, the second, third, and fourth levels of granularity here. If it's a very expensive medication, maybe it will show up, but if it's not, it probably won't. So there's subtlety here, which is why we have to always be talking to our partners about what you can and can't do. The Hospital Corporation of America, this inpatient system, is not linked to our other Sentinel partners, so it really is standalone, and we're currently not planning to go through that process of linking all these data together. So that's a unique system where the unit of analysis really is the hospitalization. So the example that we have, and this is on the Sentinel website, is a transfusion that leads to an adverse event. As long as that adverse event is expected to happen shortly after the transfusion, it should all be in that hospital system, and you can do that assessment. What you couldn't do is an exposure in the hospital that led to an outcome a month later when they're not expected to be in the hospital. That would be something you couldn't do with this environment. But again, Kevin's going to talk about all the levels of detail here. HCA, as I mentioned, has the transfusion and inpatient pharmacy data, and I tried to describe why those are the two important ones. We just can't see them in the other systems, which is why we focused on them here. And I think I'm a few minutes early. I don't know who's keeping track of me. So we are a few minutes early, so I do have some time for questions before I think next is a break. That is okay, guys? That's what we should do. Do we have a question from the field? Okay. I'll do the announcement break before, but I saw hands, so. Sure. Okay. So the question is overlap or not between Sentinel and Odyssey, which is really a data model and a set of collaborators that is run out of Columbia now. The distinction is there's two different data models. The core data models are the same, essentially. They're very similar because I was part of the team that developed both. And the distinction is how the data are curated, in my view. So the Sentinel partners, and some of our Sentinel partners have data in Sentinel and a CoreNet data model and OMOP. Those are just ways of formatting the data. I think what's really different is the Sentinel data are highly curated all the time. And any other network may or may not curate their data in any particular way. So we know, because we spend an awful lot of effort, that our Sentinel partners have populated their data model in the way that we expect. And they didn't include things that we didn't ask for. They didn't include, for example, planned visits, appointments. So you could put an appointment in a database, and we've seen others do this in other networks, and an appointment is not a visit, it's a potential visit. We know that that didn't happen in Sentinel because of the way we do our data curation. Other networks, if you don't curate the data, you're just not sure what's there. So I think that's actually the distinction versus how the data are particularly formatted. Sorry, I got 1 and 2. Yeah, go ahead. So the question is, can we track patients across our Sentinel data partners? We don't do that. So we don't link across our partners. So that person that was a Harvard Pilgrim member, Bob, he was a Harvard Pilgrim member, then he became a Kaiser member. And in this construct, they're not going to become a Harvard Pilgrim plus Kaiser member. So those two sets of information will stay separate. So they won't be linked to each other. So I have one question behind you, and then we come here. Oh, I'm gonna have to answer these questions more quickly. Go ahead. We'll have a little more time after Kevin, actually, for more questions. Mhm. So let me try to repeat and make sure I got it. What kind of useful information can we get out of those billing data specifically? Yeah, got it. So I'll summarize the question as the value of those billing data versus the others. So it's actually incredible, the value of those billing data. One, they're very standardized because it's for payment. They're in fact, most of it audited, which is a nice thing where an electronic health record data actually aren't audited. So the billing data are, particularly the hospital data, the pharmacy data, and anything that has to do with a payment. So you'll see all medically attended events. So for something like medical product safety surveillance, we're really interested in things like an exposure. So think exposure to a vaccine, which will be very well captured, exposure to a medication, which should be very well captured, and then an important adverse event. So what we won't see, and Kevin will go through this, we won't see a rash that is probably a visit that may or may not have ever been recorded that way. We will see hospitalizations. So for serious adverse events, we should see them. You certainly don't see something that didn't lead you to even see a clinician. But I should add to that, it is the value of claims plus that clinical data is really, so that adds an awful lot of value. What you're doing is you're limiting your cohort size. So that's the balance. So you can get a little bit more information, or sometimes a lot more information from those integrated systems, but your sample size might be so small that it's not worth it. So that's a balance that we actually work through on these questions with FDA about how to best use the data. I think I can probably take, I don't know what my real time is. I can probably take one more. They're telling me one, and the one was here, but we can talk at the break. And we will have questions after Kevin's talk. We have the time for some questions. Yeah. Mhm. Yes. So yes. So I'll summarize the question again. It's really about linkage. There's an awful lot of frustration that why can't there just be one database that has everybody's information? The US healthcare system doesn't work that way. So although there is an identifier, so in that Bob story, Bob does have a social security number, he's a date of birth, and he's got a name. It's not that it's not technically possible to know to do that linkage, and you could do it with clear text, you can do it, there's all sort of technical ways of doing it. It's governance, security, patient privacy, and the sensitivities of the partners to do it. In the end, if you're to link them, the data at this point would have to either live together, which, so in order to use the data as a real longitudinal record, the data would eventually have to live in the same place, which is now moving lots of information, which we're trying to avoid. I should say, we're working pretty hard on ways of using those data without moving them. So we're working on distributed analytic approaches. It's pretty novel. And we've been doing this, a colleague of mine, Darren Toe, has been working on this to try to use those data without moving them. And that's really been our approach versus trying to move all the data, which is what you'd have to do in order So there are distributed analytic approaches, which we've shown in the lab work and have actually shown with some of our partners can work. And that would really change the nature of the way we're doing this work. And that's been supported a couple different places. We've been supporting and working on this distributed analytics, which is what would address that exact problem. It's very frustrating that we know the information's there, we just can't use it. So I think we're taking a break now. Sorry, I am supposed to read something first, which means, so if you expect to buy lunch at the kiosk outside the great room, you must pre-order during the break now. This break, so if you want lunch from the kiosk, pre-order that lunch now. And I expect we'll have it for you at lunch. So thanks, and we are back here at, so this is 10 minutes, so 11:05. We're back in here. Thanks. Sure. Walk away from the mic.